Welcome. I want to thank each one of you, the physician, staff, and guests, for joining me today. My name is Wendy Herron, and I'm currently employed at Ponca City Medical Center in the cardiopulmonary department. RSV season is in full swing. According to the CDC, Valentine's Day was at its peak, so bring on May. I'd like to discuss how we can improve the patient outcomes. I'd like to look at the current recommended admission criteria, what Ponca City Medical Center's current treatment plan entails, and what are the recommended standards of care. I have reviewed the protocol from Peyton Manning Children's Hospital in Philadelphia, Pennsylvania, and I've also researched the American Academy of Pediatrics. I've also spoke with the respiratory staff and took their thoughts into consideration. What are the current standards for an RSV and bronchiolitis admission? Children less than 3 months of age or born at 34 weeks gestational age. Any child with cardiopulmonary disease, a respiratory rate greater than 70 breaths per minute, a lethargic appearance, wheezing with an oxygen saturation less than 92%, hypercarbia, atelectasis or consolidation on the chest x-ray, an inability to take fluids by mouth, or caregivers able to provide the appropriate care at home. How do we care for our patients at RSV and bronchiolitis at Ponca City Medical Center? We usually send the patients to birth and family nursing with breathing treatments every 4 hours. Some exceptions are noted with Dr. Sinton because he writes orders for assessment every 4 hours with breathing treatments as needed. On the second or third day of admission, we add chest physiotherapy and postural drainage most of the time. Nasal suction is ordered with treatments as needed, and oxygen saturations are to be kept greater than 93%. Nursing provides oral and/or intravenous steroids, antibiotics, and fluids. Would respiratory bronchiolitis pathway benefit the patients and improve outcomes? With this presentation, I would like to see if there would be a way that we can improve those outcomes by assessing the patient every 4 hours, which would be a basic heart rate, respiratory rate, work of breathing, breath sounds, and oxygenation. I also would propose that we use continuous pulse oximetry monitoring. A standard order from 1 to 3 liters via nasal cannula or oxymask to keep the saturations greater than 93%. However, patients requiring more than 3 liters would require a physician notification and an additional order. Suction as needed. Nasal suction by bulb or vacuum nasal aspirator, an NT suction, and parent instruction. Chest physiotherapy and postural drainage as needed with a parent instruction as well. Nebulizer treatments as needed. RSV is airway edema, not bronchospasm. An albuterol trial for wheezing, and if it is successful, then every 4 hours is needed, as well as racemic epinephrine trial for Schreider, and then every 4 hours as needed if it is successful as well. Atrovent has not been proven efficient. However, if the patient's parents have a history of reactive airway disease or asthma, it can also be used every 4 hours as needed, but not to exceed more than 3 doses a day. The main thing that I would like to focus on is education of the parents, because the children usually have siblings at home or they plan to have more children in the future. So I would like to have an RSV and bronchiolitis packet made for them, explaining what it is and how the treatment is to be done. We need to inform them of the isolation precautions and hand washing techniques so that it's not spread from family member to family member. I also believe that chest physiotherapy with postural drainage is something that the parents can do as well. And to make sure that each parent is comfortable using nasal suction. This would be a patient-centered care through a team approach that will improve the patient outcomes, decrease the lengths of stay, and avoid a cookie-cutter healthcare. Thank you.